Chapter 27, Intrapartum Emergencies. There are a few placental abnormalities that can be considered medical emergencies. These conditions are not overly common, so I will just provide brief explanation for each. These are due to abnormal adherent of the placenta. Placenta accretia occurs when the placenta grows too deep into the uterine wall. This can make it difficult for the full placenta to detach as a whole unit after birth. This will put her at higher risk for postpartum hemorrhage because it can leave small fragments of placenta in the uterus. The uterus identifies those fragments as something foreign and will not stay contracted. If the uterus does not stay contracted, it becomes boggy, and then that will put her at risk for postpartum hemorrhage. Placental incretia is when that placenta actually penetrates the uterine muscle, and placental percursia is when the placenta goes all the way through the uterine muscle. These are considered emergencies since massive postpartum hemorrhage can occur. If this happens, you now have to think back to that podcast on that postpartum hemorrhage. And remember, we are very concerned about that hypovolemic shock due to the loss of blood. Watching for an increase in pulse and decrease in blood pressure is crucial. Monitoring urinary output is necessary, as if there's not enough blood to circulate to the kidneys, then to have them working effectively. If the kidneys cannot work effectively, they cannot filter and get rid of fluids. It's a vicious cycle at this point. I've mentioned prolapse cord in other podcasts, and now we will learn more about why it happens and the management for it. A prolapse cord occurs when the umbilical cord falls down after the rupture of membranes and is being compressed between the fetus and the pelvis. See figure 27.6 for pictures of the various types. Remember that the umbilical cord is that baby's lifeline, so if it's being compressed, then there's a decrease among the amount of oxygen reaching that baby. A few factors that can cause a prolapse cord includes that fetus that remains high at the high station. Remember, the station refers to the correlation between the fetal head and mom's ischial spines. So if the station is high, typically greater than a -2 station, then once the water is broke, the fetus and cord will drop into the birth canal, and if the cord drops into there first, then that risk for the prolapse cord has increased. Other risk factors include a fetus in that breech position, which is not head down, a small fetus, and a woman with polyhydramnios. Manifestations vary depending upon which type of prolapse it is, but you will see a decrease in that fetal heart rate. Therapeutic management includes to relieve that pressure on the cord. This is done by the nurse or the provider putting on a sterile glove and doing a vag exam and pushing the head or the presenting part off the cord and holding that presenting part off from the cord. This entails that person keeping their hand there, keeping the pressure off from the cord. An emergency C-section is called, and that person keeps their hand there until delivery of the infant. If pressure is not kept off the cord, the fetus will not receive oxygen and can die. They can put the woman in Trendelenburg position as well to help keep the pressure off from the cord. They can try to put her in a knee-chest position as well, or elevate her hips to try and help alleviate that pressure as well. Providing oxygen to mom, having other people prepare for that C-section as far as IV starts, if not already, get the consents if there's time, preparing for a compromised fetus, are all things that need to be done. Nursing considerations include trying to keep mom and family calm and reduce their anxiety. It can be a very stressful time for all those involved. A tear in the uterus can cause a uterine rupture. They can be classified as complete, partial, or dehiscence. Uterine ruptures are rare but considered a medical emergency to both mom and fetus. The risk is higher in a woman who has had a previous C-section or uterine surgery. The greatest risk is when the woman has had a classical incision with those surgeries. A classical incision is one that is vertical instead of the more common low transverse incision. The decision on if a woman can have a VBAC is due upon which type of incision she's had with previous surgery. A uterine rupture can occur even on a woman with an unscarred uterus and is more common in a woman who are high parity, which means many pregnancies, because that uterus has been stretched many times, so it will thin and cause greater risk for abruption. A woman experiences intense contractions, and a woman who doesn't have adequate resting time between the contractions to relax. Manifestations can depend on if it's true rupture or a dehiscence. A small dehiscence typically does not cause pain and may not affect labor except that it can stop or stall the labor. A large dehiscent may cause pain that does not subside even with analgesics. Others include the woman feeling like something ripped. She can have chest pain, hypovolemic shock, cessation of uterine contractions, decrease in fetal heart rate, and or late decelerations. Therapeutic management is to stabilize mom and baby and prepare for immediate C-section. Many times a hysterectomy is needed at the time of delivery. Nursing considerations include knowing the woman who are at high risk for uterine rupture and closely monitoring for any manifestations. In some cases, it may not be detected until postpartum, so she is high risk for postpartum hemorrhage, so good assessment skills for that is also needed. A uterine inversion is rare, but it can occur when the uterus completely or partially turns inside out and typically occurs during the 3rd stage of labor. Many times there's not a single cause, but there are risk factors that include pulling on the umbilical cord before the placenta detaches from the uterine wall, fundal pressure during birth, an abnormally adherent placenta, or weakness of the uterine wall. It is detected when it's noted when the uterus is absent from the abdomen or a depression in the fundal area is present. Sometimes the interior of the uterus can be seen through the cervix or it's protruding into the vagina. Massive hemorrhage, shock, and pain occur, and she has severe pelvic pain. Quick action is needed. The provider tries to replace the uterus through the vagina into the normal position. If this is not possible, surgery is required to replace it. A hysterectomy may be needed. You are anticipating massive blood loss, so anticipating the need for blood products. Be sure 2 large bore IVs are in place for the high volume of fluids that will be needed. Oxygen will be provided. Many times a tocolytic med will be given to keep the uterus relaxed. Nursing considerations include stabilizing the patient, preparing for blood loss, and being prepared to replace fluid. Frequent monitoring for signs of hypovolemic shock. Foley will be placed to monitor for that urinary output. Anaphylactoid syndrome is also known as an amniotic fluid embolism. It occurs when amniotic fluid is drawn into the maternal circulation and carried to the woman's lungs. The fluid can contain skin cells, vernix, hair, and meconium, which can cause obstruction. The women still complain of shortness of breath. You will notice respiratory depression and depressed cardiac function. She may go into cardiac arrest, so treatments include CPR, oxygen, mechanical ventilation, correction of the hypotension, and blood components therapy.